For any we got here. All right, hopefully you can all see my screen. And I'm going to leave the little sidebar open in case we want to go back and forth through slides. I'm going to put this over here. All right, so here's my presentation today about what we see in patients with Parkinson's disease, or I should be more politically correct and say clients or people with Parkinson's disease. Just a little review on the Parkinson's etiology. So hold on, let me get this out of the way. Here we go. So the cause of Parkinson's, as we know, is a neurodegenerative disorder. What happens with Parkinson's is we have a reduction of the dopaminergic neurons in the basal ganglia. So, and the basal ganglia is responsible for our motor control, motor learning, executive functions, behaviors, and emotions. And then the reduction of these neurons leads to a reduction of dopamine, which is a very important neurotransmitter, as we know, in our system. The suspected cause are a variety of genetic and environmental factors. There is now even a type of PD that's called familial PD. So there are some strong genetic links that are being found, but the vast majority is unknown. So when we meet someone with Parkinson's disease, we usually see the outward symptoms of the person. We see changes in posture, we see rigidity, we see this forward tilt, rounded shoulders, forward head. We see lack of facial expression. We see some flexion at the elbows and wrists and reduced arm swing along with some shuffling gait. As the disease progresses, these physical symptoms are stronger or more evident. What we tend not to see are the non-motor symptoms of our patients with Parkinson's disease until we get to know them a little bit better. So the reduction of dopamine also causes changes in cognition, depression and anxiety, fatigue, sleep disturbance, pain, gastrointestinal dysfunction, cardiovascular dysfunction, bowel and bladder dysfunction, sexual dysfunction, and many other symptoms. These are just the more prominent ones. And today we're going to talk about visual changes, including hallucinations. So there was a great study done in the Netherlands from a neurologist who I'm completely in love with. Her name is Carla Jan Borum, and she did multiple studies. She did a tiered study. And within this, she determined that approximately 68% of people with Parkinson's disease have an ophthalmological condition that interferes with their daily function. And we're going to highlight some of those conditions. So one of the things that can happen is the dopaminergic changes in the retina start to cause decreased contrast sensitivity, decreased light adaptation, color vision deficits, visual field deficits, central and peripheral, and glare sensitivity. So as the dopamine levels fluctuate in the body, the retina can actually deteriorate, causing these issues. Also, as the dopamine levels drop in the system, these people have more difficulty with ocular motor control, just like they have issues with controlling their musculoskeletal system. They also start to have problems with controlling their eye muscles, which can cause problems with saccadic function, so being able to jump their eyes from one target to the other, convergence, including binocular vision skills, so eye teaming with the saccades for the convergence, and for pursuits in fixation. So these ocular motor issues, if the eyes are not teaming properly or converging properly, can also lead to double vision. It can be a common complaint. So another thing that can happen is decrease eye lubrication, usually due to eyelid dysfunction. So what happens is you have a decreased blink rate, which causes the eyes to dry out. You can also have blepharospasm, which is more of a clenching of the eyelids. And also this population is prone to dehydration, so that can affect the eye lubrication as well. So this group ends up with being diagnosed with dry eye, and also will with their dry eye, they can have eye pain. They'll talk about a visual discomfort and also excessive tearing. And then another thing that can happen is as the dopamine levels change, we can have dysfunction in the visual cortex, which can lead to visual, spatial, and perceptual impairments, visual hallucination, and changes in visual attention. Also look at the changes in visual attention as kind of buddies with the changes in ocular motor control, which we'll talk about a little bit more as we go on. So contributing factors to these visual issues include, as you can see on the right of the screen, the levodopa equivalent dose. So that's the levodopa equivalent dose is how dopamine is being replaced in the body. So those prescribed medications that are meant to cause synthetic dopamine in the system, as those levels go up and down throughout the day between doses, or as they're down cycling from one dose or up cycling into a different dose, as those levels change, you can see visual changes as well as much as you can see other changes in the person's system. Other contributing factors, as I mentioned before, this population is really prone to dehydration. Their medications can be dehydrating, and because of lack of mobility and interest with food and beverage intake, they are very much prone to dehydration. Also, decreased swallow can affect a person's ability or desire to intake more water. So this population is very prone to dehydration. Poor sleep, as mentioned, that's one of the symptoms. If they're not sleeping well, then that is going to affect their body's ability to use the synthetic dopamine. Malnutrition, again, for the same reasons as the dehydration. It's very common for this population to struggle with maintaining proper weight. And if they don't eat, then they cannot synthesize the medication properly, and then therefore leads to a host of issues. And also inactivity. So as a person with Parkinson's moves, it actually helps them helps their system utilize a synthetic dopamine. So if they are not moving, they become even more rigid and have trouble processing the medication. So it's important for us as therapists to pay attention to the potential for visual changes for people with Parkinson's disease. Multiple studies show that this population has decreased complaint or report of their visual changes. So especially double vision, believe it or not, blurry vision, even decrease awareness of color vision. These things could be happening, and the person just does not think to mention them. And in these studies, there's a lot of different rationales that were explored. Maybe the comorbidity of depression interferes their ability to report their symptoms, or just that there's just so many symptoms going on at the same time that it's not the one that they see as most pressing. And then also if someone is experiencing visual changes and also has comorbidities of cognition, attention, depression and hallucinations, they're all going to play off of each other, as we'll talk a little bit more about. And then if these people are having visual changes and have these comorbidities, especially decreased cognition, they're going to require extra time for instruction. So we want to make sure we give them what they need. So further impact of visual dysfunction. So for people with Parkinson's disease, they have decreased proprioceptive awareness of their body, so which actually makes them more visually dependent for their mobility and interaction with their environment. So therefore, if they have visual changes, if they're having blurry vision, decreased depth perception, that is going to make it even harder for them to negotiate their environment than it is just with their rigidity. And of course, we know as occupational and physical therapists that this has a direct effect on reading, ambulation, and driving. And those are big issues. So one of the tiers of the study that I mentioned before looked at people with Parkinson's disease with low vision and quote unquote healthy individuals with a low vision diagnosis, or visual changes is how they worded it. And what they found was that when someone with Parkinson's has a visual change, their interference with their daily activities is much greater than someone without Parkinson's. And the guess is because they're so visually dependent, and also because of their other symptoms, their decreased mobility. It just makes it even harder for them to use a variety of adaptations that are available for people with low vision, and cognitive dysfunction. So interferes as well with their ability to utilize a lot of the common strategies that we would give someone for low vision. So as a therapist, when, as someone who is either working in a low vision program or not working in a low vision program, there are certain questionnaires that we can use to bring issues, visual issues, to the front of the conversation for people with Parkinson's disease. So as low vision specialists, we're familiar with the revised self-report assessment of functional visual performance. Of course, that can be used. If we wanted to look into other screening tools that maybe highlight the differences between the neurological side of the visual changes, maybe more highlighting more of the ocular motor issues, the double vision and things like that, which may not be so present in traditional low vision screening. There's a couple other questionnaires that can be utilized. So there's the ophthalmologic supplement to the NEIVFQ. If you have experience with visual remediation, or even maybe if you work in a neurological setting, you may have come across the Convergence Insufficiency Symptom Scale, which talks about all things that are affected by decreased convergence. And from the studies that I had mentioned prior from Carlegen Bourne, they're actually trying to release a Parkinson's specific visual scale, which would be called the VIP-Q, VIP-Q, which would be very handy to have for Parkinson's clinic. And it's a questionnaire that can start in the doctor's office and also be used as therapists to help make sure that all the proper services are being referred for. There are also questionnaires that are PD specific questionnaires that they have a couple questions in there that help pick out visual issues. So let's say you work in a low vision program that's also affiliated with other services, traditional OT, PT, things like that. You could encourage them to have their patients fill out one of these PD non-motor symptom questionnaires. And if they're reporting visual changes, encourage them to look more into that and refer to low vision as appropriate. So during the visual assessment, again, in low vision, we look at visual acuity, color and contrast, glare sensitivity, visual field, and eye dominance. But if we come across a patient with Parkinson's disease, I know there's a lot to do in that assessment, or maybe you look at this in a follow-up visit, but trying to do a quick screening for convergence and binocular vision skills or eye teaming, you can have them shift their gaze in directions or try to do some pursuits and see if they can maintain visual fixation on a target, or if the target becomes double as they gaze in any particular direction. If you look at their convergence, now with older adults, it's tricky to manage convergence because most people are using some type of eyeglass, and you're also dealing with the focal availability of the lenses. So as you bring the target near, it does get blurry. But for even an older adult, what I would consider quote unquote normal for an older adult for convergence would be about 6 or 7 inches. The target may be blurry, but it shouldn't be double. In a younger individual, so someone who's a younger adult or a teenager, normal convergence can be anywhere from 2 centimeters to 2 inches, just to give you a little perspective. And then also we want to look at how is their environmental scanning if we can. For example, people with Parkinson's are going to have motor control issues that affect their ability to move their head. And they're also going to be less likely to, they may have troubles coordinating increased difficulty coordinating their eyes. So how is their environmental scanning? Can they actually rotate their head to scan the environment, or are they trying to scan with their eyes and then having double vision or decreased ability to look around a room? You can, if you have some artwork on the wall, can you find me the picture with the flower in it, something like that? See how well they're able to look around their environment, especially if that person is driving. So when, again, in the clinic, there are certain things we can observe in the clinic, and then there are certain things that we're dependent on self-report. If you are providing services at home, then you may be able to have them demonstrate some of these activities. Or, due to time limitations, you may be asking a caregiver, but these are all, the general areas that we look at for low vision. When looking at, for example, writing, this population is not only going to have trouble with their writing because of visual changes, but because of rigidity and decreased coordination in hands. So, trying to tease out which is the issue there. Stairs in this population, when looking to the right, one of the common problems that I come across is when I ask the person, when you're going up and down the stairs, how well do you feel you see the stairs? And especially if I'm with someone in their home, quite a few times I've had people tell me, well, the stairs look kind of like a ramp because they can't see the beginning and end of the steps, which is common for people with low vision. But sometimes when people with Parkinson's disease make that kind of comment, therapists assume that it's a visual perceptual skills issue, but it actually can be more of a contrast sensitivity issue. So, and then locating items, dressing, leisure pursuits, driving, again, these things are all going to be compounded by their rigidity and lack of physical mobility as well. So some ideas, I included some ideas in this PowerPoint of suggestions to help people with Parkinson's disease when you come across certain visual issues. For example, double vision. So double vision, when people report double vision or don't report it and we find it out some other way, it's usually more apparent when people are tired or at the end of their medication dose. So most dopamine medications need to be taken every 4 hours. So if someone's at, 3.5 hours, 3 hours and 45 minutes, and they're tired, especially on top of that, then that's when they're going to be more likely to have the double vision, especially when those doses are wearing off at the end of the day. It can also be a sign that maybe they're not, if they're having this issue coupled with other movement issues, that they're under medicated. So, or also if the person is not practicing good self-care, I find that when people are dehydrated or have not eaten in a while, they are also more likely to get double vision. So these symptoms may decrease with rest or their medication dose, or sometimes they can actually remedy with stimulation. So on the opposite spectrum of these people being tired, sometimes they are also understimulated. Maybe they've just been staring blankly at a TV for hours or out a window. And, so if the cause is understimulation for their double vision, I've actually had them hold out their finger or their thumb and try and encourage them to focus on it. And actually, just like you would exercise an arm or a leg, encourage them to bring their eyes together to focus on a target. And they just don't realize that they have the power to do that sometimes. So if the double vision, the diplopia, is persistent and is just, especially as the disease progresses, it can be less and less correctable, then the person may benefit from referral for prism glasses so the image can be shifted to where their eye is lying. And sometimes we'll see where the eye will just go like amblyopia. It'll just shut down, as we see with other neurological diagnoses. So the person is not getting double vision. But either way, these issues can affect depth perception. So with visual field, so we mentioned that the changes in dopamine can affect the retina's ability to function, and the deterioration usually happens from the periphery of the retina and then works its way in. It's not categorized as glaucoma. It's not happening because of changes in pressure in the eye, but we are seeing some changes, and it can fluctuate, which is the crazy thing too. So sometimes the visual field can be better than others, all depending on that dopamine level. But if you are noticing decreased visual field, we want to, again, make sure that we have as much cervical range of motion as possible, that they can turn their head, we want to work on environmental scanning, page scanning, consider if the person is driving, consider how this is affecting their driving. And if the field constriction is severe, then it can start to affect self-feeding and you'll see in this for someone with very severe PD that also has visual field loss, they may pause with their food before they get to their mouth because it's out of their visual field, and then they have trouble finding their mouth with their food. So dry eye, for someone who is experiencing dry eye, we need to educate them on their need to blink. If their eyes are painful, using those artificial tears, closing their eyes, resting them a little bit so they can lubricate, and really hammering about that hydration, their need to drink water, just so much water all day. This population just cannot drink enough water. And if the artificial tears are not enough, they can use a more, the eye doctors can prescribe a more viscous gel form of artificial tears that stays in the eyes longer, especially if they're unable to close their eyes fully. So, so for changes in color and contrast sensitivity, you guys are the pros at this, right? Looking at appropriate lighting, marking colors, stair markings, magnification, sometimes for the color, if that helps, or contrast issues. A caregiver should definitely be aware of how these changes can affect the person's ability to interact with objects in their environment, how it puts them at risk for falls, finding objects in their environment, finding notes that loved ones leave for them on the counter, and maybe they don't even see, and eating. So acuity, patients with, PD benefit from glasses. Let's see, sorry, I'm looking at how I wrote that. I don't really like how I wrote that, but anyway, so people with Parkinson's disease that are experiencing changes in visual acuity, often when they go to the doctor, like many of our other low vision patients, the doctors will say, well, I don't really know if updating your glasses will help you. So maybe I'm going to save you that money. I'm not going to update your glasses. But what I found for the people with PD is it almost always helps them. I always tell them to push for the eyeglasses, even if the doctors say, no, we don't know if this is going to help you. I say, if you can afford them, if you can manage it, please, please, please get them. Almost always it does make a difference. And another thing that can make a big difference is using glasses, separate eyeglasses for near and distance. So, or if they really don't want to part with that progressive eyeglass, keeping the progressive eyeglass for distance, but then using a separate near eyeglass for near. And the reason for this is because of the changes in ocular range of motion. People with PD frequently have trouble accessing that lower near part of their eyeglasses that they would use for reading. So when they go to read, most of the time, instead of moving their eyes, they're maybe flexing their head a little bit. And then they're trying to use the distance part of their glasses for their reading. So, usually having separate eyeglasses for reading, especially if have a more active person with PD who's still trying to use computer and, read and, leisure activities, fine motor tasks, are almost always going to benefit from a separate pair of eyeglasses for reading, even if they have a progressive prescription. So, of course, we know with glare sensitivity, we use the UV shields, which are fabulous, hats, visors, things like that. With the Parkinson's population, because of their changes in mobility, I just encourage people to look at making accommodations for glare more global, like more environmental, and not just putting the glasses on and off, because if the glasses are across the room, they're not going to get up and get them. And likely they're not going to tell someone that they need to get up and get them. They're just going to sit there and squint or close their eyes or just take a nap. So putting filters on the lights in the room can be much more effective, or shades or things like that can be much more effective than the UV shields. Not that we shouldn't use the UV shields, but you kind of have to look at the person and plan for the situation. So when we have issues with saccadic dysfunction and visual attention, of course, if the person is trying to read, we're using line guides. Large print works much better than using a magnifier. Not that magnifiers can't be used, but a line guide with large print is going to be much easier than having to manipulate a magnifier and something underneath the line. We can make goals and we can practice this with them using, a line guide for, making appointments, preparing their finances, reading the mail, and we also want to encourage the patient to slow down their pace to allow time for their eyes to move, and also time for their brain to absorb what they're seeing, because that speed really reduces. So encourage them to look over the line multiple times if needed, and to tell them, your eyes are only moving so fast now, you have to slow down, because what will happen is people will say, I'm reading it but I don't understand it, or, oh, I missed that in my environment. And, the name of the game is you have to slow down because your brain's just not working that fast. Hallucinations can be tricky to work with. Of course, we want to identify that hallucinations are not real. We also want to educate on the prevalence of hallucinations with Parkinson's disease and how they happen more frequently when people are fatigued, dehydrated, malnourished, if they have other visual changes, or if their medication dosing is very high or very low. If you find that you have a patient whose medication was just changed and they're starting to hallucinate, then you should encourage them to tell the prescribing neurologist or movement specialist, just in case maybe they made too big of a jump with the medication dosing, and the person's system is having trouble adapting to that. So, another phenomenon that we look at for hallucinations, if the person is having visual changes, they have visual field deficits, visual acuity deficits, we're all aware of things that can happen like Charles-Bonnet syndrome, where the person is not getting the full visual image, their brain is not getting a full image, so then it starts to make up what it sees. So in that case, in the moment of the hallucination, if the person is more persistent that maybe it is real, you could have the caregiver to do things like turn the lights on and off, have the person look away and look back, and sometimes changing the environment or shifting the gaze and getting the brain, as the person brings their head back, then the brain looks at the area differently and the hallucination goes away. So that can be a strategy as well. But always go back to those self-care issues. And then, visual, perceptual, cognitive changes, and any of the above, we all know the strategies of simplifying the environment, decreasing clutter, increasing organization, increasing contrast. And this population, as with any other population, needs to be stimulated. They need exercise. They need cognitive and physical stimulation to keep their neurological system functioning as well as possible. All right, so this is just a little reiteration here. We're kind of pulling it all together. When making recommendations, always remember this population's limited mobility, ambulation, and just the limited mobility of their entire body, their dexterity, head movement, things like that. Tremors, if the person has tremors, obviously we're going to use more hands-free magnifiers, stand magnifiers, loops, things like that. decreased cognitive function, so limited problem solving, attention, and memory, which goes with the loss of dopamine. These people are very capable of learning, but the repetition needs to be higher, more reinforcement. And then also the comorbidity of depression, which may affect their desire to follow through on the adaptations. So, and here when we talk about keeping devices of recommendations as basic and easy as possible, this population, because of everything that they're dealing with, gets overwhelmed very easily. So as I talked about before, using a hands-free magnifier with a light as possible. I always find this, many people, as we know, have that favorite reading chair. So the hands-free magnifier that stands on the floor and comes up over their chair or clips onto the table next to them can be great when positioned properly. Having multiple devices for each room, because they're likely not going to carry the devices back and forth between rooms, or if they have to get up and go to another room to get the device, then they're just going to say forget about it. Motion lights or lights on timers are great. Reminding the person with Parkinson's to talk to the people in their environment about their visual needs. I can't tell you how many times I've been in people's houses with PD, and we bring all these visual issues to the surface, and the spouse or caregiver says, I had no idea. They're like, why didn't you talk about it? They're like, I don't know. There was just so many other things to talk about. So, and the overarching emphasis on self-care to keep the dopamine levels regular. And the importance, if you are seeing them for low vision and you only get so many visits to work on, issuing them their low vision equipment, you can always refer to continued traditional OT for carryover of these recommendations, because they need so much repetition. And here again, we talk about those contributing self-care factors: sleep, hydration, nutrition, depression. Stress is a big one. Many times when someone has a visual change, it'll follow a period of stress, activity level, decreased activity level, or fatigue, compliance with medication, and the need for education. I figured I would share a slide of just some recommendations that I've made for a couple of my people with PD. So I created a large print organizer for one person who was living in an assisted living. She's in the independent side of an assisted living, with nice big bold medications, really simplifying and condensing her materials, getting them out of the drawers and all around the house where they can be forgotten about, and blowing them up and condensing them into a binder. On the right, you'll see the carpet pads on the stairs, and we'll be done soon. And I would love it if people have other ideas as well. I mean, we've all done the tape markings on the stairs, but for people I've had a couple people who've agreed to use these carpet pads, and the patients love them. They find that it really makes the stairs stand out from each other, and they can be really great. When using a magnifier, it's a picture of a magnifier on the calendar, just allowing them to rest their hand, if possible, on the calendar, even though it doesn't put the magnifier at maybe the best focal distance, it's better than nothing. The center picture that looks like an egg on the ceiling is me putting amber acetate film over lights. I got the acetate film from Amazon, and I cut it to fit it over the lights. So this gives us a way to decrease the glare in the entire room, and the person can be in their apartment and not have to have their UV shields on. And then also using lights with sensors. There's a wide variety of lights with sensors. Some of them are pretty junky, as you've probably come across, and some of them are better. This particular one is wired into the house, so it's a little bit more reliable and has a better sensitivity than most. And then here again, communication, building a team, physical therapists, occupational therapists, low vision specialists, doctors, communicating as much as possible. And, and of course, bringing in the caregivers who unfortunately are frequently overwhelmed, but trying to help them with as much information as possible without totally inundating them, and slowly reinforcing these major concepts. If home OT or mobile OT is available, that can be very helpful for carryover as well. Someone that can actually get in the home is really essential for good carryover. And then just say knowledge is power. So we want to improve understanding of what the patient's going to. We want to improve treatment success. We want to improve caregiver awareness, and we want to improve patient confidence, get them to better understand their body and how to take care of it. So with that, I will say, any questions while I have the PowerPoint open before I close it, or anything anyone would like to share about their experience with someone with Parkinson's and low vision? Just feel free to unmute yourself and talk.
Kim, it's Stacy. I was just going to say about the overhead sensor lights, like the ceiling lights. What I'd never even thought of that. What a good idea that is, because usually you recommend some sort of sensor light for like a lamp or something like that instead. But to do an overhead, I didn't even know you could do that. So that's a great idea for those that just to be able to walk into the room and the light turns on.
Yes, they're more popularly used in bathrooms and closets and smaller rooms, but you can really use them in other rooms. Most people, have started to use motion lights by using the little battery operated ones and maybe put them in their stairwell and things like that. But the problem is they run out of batteries and then no one changes the batteries. So it's always good to look for something that plugs in or can be wired into the house.
One other thing I was thinking too with the lights, I was on another call. I think it was I'm part of the Connecticut OT Association home care group. And somebody had mentioned, I think on there, was it on there? I don't know, but it was the toilet lights that you can clip onto the side of the toilet, and and it illuminates the inside of the toilet bowl to you can pick different colors or LED colors, but it helps for those with low vision of knowing where to pee, because you lack the contrast with a white bowl. And then even using it at night, so you're not flicking on, a bright light in the bathroom and then the difficulty with your eyes adjusting, it helps kind of illuminate that area.
That's a great idea.
I tried that at home before I recommended it, and we had some fun. My teens were loving blasting the colors and stuff. But I also wanted to add smart plugs. Alexa, she went on. A lot of times I'll recommend to plug into the Nest or whatever they happen to have.
Yes.
If they can enunciate well enough.
Yes, absolutely. Absolutely. Yeah, there's lots of different things out there. The clapper is still around somewhere. So just being creative and finding what works for your client. I love the toilet light idea. I never even thought about that. And that's great because a lot of people with PD also have frequent urination. They're up a lot at night. So that's awesome.
For the people with visual hallucinations, because we see it in the concussion patients who have visual deficits, we see it in the stroke patients who have visual deficits. Is there anything from a remediation standpoint that could be possibly done to help with reduced visual hallucination? I loved your idea of just having them stop turn their head, scan back, change the lighting. Just curious, is there any research that's been done to show anything else that we can do from a remediation standpoint?
Yeah. Well, those remediation strategies that I gave are mine. Those didn't even come from research, but they're Kim strategies. But a lot of times you just want to make sure that there's not a chemical change within medication interactions. So quite frequently, if people are on strong medications, that can contribute to the hallucinations. So always double checking the medications. And I know with PD, I don't know so much about other diagnoses, but with the PD, it can be very linked to dehydration as well.
It's good to know.
Also, they're more common in people who are more sedentary, the hallucination. So just getting them moving and interacting more
Good to
and
know.
cognitively and visually stimulated.
Yeah.
So
Does anyone else have any input or questions? I was wondering if Kim, especially the page where you listed the screening and assessment tools, is it possible I could just do maybe a screenshot and I'll send that to the folks,
sure.
including your recording.
So yeah.
Does anybody else have a screenshot they'd like Kim, or a slide that you found that was extra interesting that you would like maybe Kim
I
would
took
share?
pictures with my phone.
Oh, there you go.
Yeah.
That
So
works.
here's the questionnaires. So
Is the NEIVFQ, is that free?
yes,
That's free? Okay.
you can find it. It's a little tricky. If you have trouble finding it, let me know. I have a PDF downloaded somewhere. So that you can use with any neurological diagnosis. And the Convergence Insufficiency Symptom Scale. For the Convergence Insufficiency Symptom Scale, I would use that more for higher functioning people with PD. As they have more and more cognitive functioning, lower functioning people, if they have more cognitive symptoms, it can sometimes be hard to weed out what's visual convergence and what's changes in cognition. And then I'm hoping they'll release this BIPDQ sometime soon. So that's that screen. And then this is the other visual assessment screen, just talking about things to make sure you include.
Good to know.
So.
Do any of you see a lot of Parkinson's patients? In home care?
Not anymore, but that was awesome. Thank you.
Yeah,
You're welcome. I'm hoping that as the awareness of visual changes in people with Parkinson's disease expands, especially with the latest research, it's just really boomed in the past couple of years, that neurologists are going to be, actually, hopefully, they could be sending people for low vision services. They could be sending them, or at least send them to OT or PT, and, say, is having trouble with their adjusting to their visual changes, just because it's just, and like I said, there's just so many other things. I think when you're dealing with cardiovascular issues, GI issues, movement issues, it just goes, on the wayside. And unless the person is really persistent about it, it just doesn't get the attention. It's like, when someone goes into the ER and they have, a brain injury and a femur fracture, and then they have a fractured finger, the finger doesn't get any attention. Not that should be the equation, but it's just, it kind of gets swept under the rug. But then in the long run, it becomes a big something that really interferes with their function.
Absolutely.
So,
It's excellent.
and I have used low vision codes for helping someone. I did have a patient and their primary symptom, they were PD, and their primary symptom was the visual changes, and I did use low vision codes. That was in a clinic.
For the treatment diagnosis,
Yeah,
you use
yeah,
low vision codes.
yeah,
Okay.
and with Parkinson's disease. So but I think, as you know, as far as if you have to use that low vision code, I don't think it's really a necessity unless you're giving out magnification devices, obviously, and you have to get that script signed off.
Got it.
So
Kim, thank you so
anyway,
much.
thank you for having me and for
This-
letting me rant about my ramble. No, I shouldn't say rant, ramble on about my my PD people. But I think the big thing is